we are looking at a case. A 2-week-old female baby has come. It's a neonate basically, and presenting with some lethargy, irritability, poor feeding, and even the weight gain has been compromised. Poor weight gain. Now, when we are having a physical examination, we could see there are some ambiguous genitalia, and there is also clitoral hypertrophy. That means there is some masculinization happening in the girl child. Plus, there is some hyperpigmentation of the labia region. Now, when we were doing the lab investigation, it was seen there are high levels of 17-hydroxyprogesterone, means androgens have increased, and by this time, we understand it is appearing to be a case of congenital adrenal hyperplasia. And how is that? Because of the presentation, physical examination, and the lab findings. And what could be the incorrect statements now regarding the involved organ? That is, of course, adrenal gland. The histological specimen has been given, and some clinical findings. They need to find out which of the following statements are incorrect. Now, when we are looking at the histological picture of adrenal gland, we understand it is going to have a capsule, and on the capsule there will be some blood vessels, some of them reaching the cortex region, and some of them can go to the medullary region. In the cortex also will have 3 divisions: zona glomerulosa, which is shown here as marker A, the fasciculata, marker B, reticulata, marker C, whereas the marker D will be the adrenal medulla. And as I suggested, the arterial supply to medulla can be separately given as shown here. Now we need to look at the arrangement of these blood vessels, which are basically fenestrated sinusoids supplying the GFR, that is glomerulosa, fasciculata, reticulata of the adrenal cortex, or the fenestrated sinusoids in the region of adrenal medulla. So we'll be looking at the histological details as well, but presently, as the options are mentioning, embryonic source of pathological cells is intermediate mesoderm. Now, where is exactly the pathology of congenital adrenal hyperplasia? See, it is an autosomal recessive disorder, some genetic mutations leading to deficiency of enzymes involved in production of some of the metabolic derivatives, basically steroid-based hormones. So which enzyme are we talking about? There could be several, but specifically 21-beta hydroxylase. And due to deficiency of this enzyme, what happens is the zona glomerulosa and fasciculata, the hormones they produce are decreased. So what is zona glomerulosa producing? Mineralocorticoids like aldosterone. It goes down. And what about the zone V, zona fasciculata? There you have glucocorticoids like cortisol will be going down due to deficiency of this enzyme, 21-beta hydroxylase. Now, if we have deficiency of aldosterone or cortisol in the blood, the feedback mechanism which works backwards towards the central nervous system, basically we are talking about hypothalamo-pituitary axis, that feedback mechanism will be compromised. If you have deficiency of aldosterone and cortisol, that will tell the hypothalamo-pituitary axis to become activated, and pituitary will be now increasing the secretion of ACTH, adrenocorticotrophic hormones, which will then come and ask the adrenal gland to secrete more adrenal hyperplasia. So congenital adrenal hyperplasia. But then maybe there is increased ACTH, which then further leads to increased 17-hydroxyprogesterone steroid genesis enzymes. These enzymes will ask the zona glomerulosa, zona fasciculata to increase their secretion, which cannot happen. It cannot happen because already due to genetic mutation, we had the deficiency of 21-beta hydroxylase. So these zones are unable to produce any more secretions. So what happens is this 17-hydroxyprogesterone, due to increased level of ACTH, is spilling over to the zone C, which is zona reticulosa. reticulata, and there you'll find a lot of androgens are being secreted. And now, because there are a lot of androgens, the virilizing effect or masculinizing effect, the female baby is now showing clitoral hypertrophy, ambiguous genitalia, a female showing male features due to increased androgens. Anyhow, what about the embryonic source of the pathological cells? Is it coming from intermediate mesoderm? See, this is adrenal gland which has outer cortex, inner medulla. If you say cortex, the adrenal cortex is coming from the same source from where the kidneys come. So kidneys and adrenal cortex, they come from intermediate mesoderm. That is a correct statement. Intermediate mesoderm is going to form the adrenal cortex, and there is something wrong with the adrenal cortex, basically starting from zona glomerulosa and fasciculata. Plus here you should also remember adrenal medulla, which is having some sympathetic neurons, is actually coming from neural crest cells. So it is the neural crest cells derived adrenal medulla which will have some sympathetic neurons. Okay, so choice A is fine. It is not the answer because we have to find out the incorrect statement. What about the choice number B? Is the karyotype going to be normal? 46XX? Yes, the karyotype is normal. The problem is, despite being a normal female, she is behaving like a male, or masculinization has happened due to over secretion of zone C, zona fasciculata, more of androgens. Okay, so that means choice B is a true statement. What about choice number C? Will there be serum electrolyte levels like this? More of potassium and less of sodium? Yes, salt wasting, congenital adrenal hyperplasia. And what is this salt wasting? See, congenital adrenal hyperplasia, there is deficiency of 21 beta hydroxylase, inability of zona glomerulosa to produce aldosterone. Aldosterone is normally working at the distal convoluted tubule for sodium absorption and potassium excretion. But if I don't have aldosterone, then I cannot conserve the sodium. So there'll be natriuresis. And on the other hand, hyperkalemia. So retention of potassium and loss of sodium. Salt wasting type of congenital adrenal hyperplasia. That is also a true statement. Now, obviously, we wanted to find out the incorrect statement, and that is none other than choice number D. Now, when you say your answer is choice number D, explain why. Because it is understood increased secretions of zone C, that is zona reticulata. There were more of androgens that was resulting in sexual maldevelopment, ambiguous genitalia, clitoral hypertrophy, and all that. So it is not zone B, it is actually zone C. Hence, statement D is a wrong statement, and that is the answer of exception. By the way, why there was a hyperpigmentation in the labial region? That is due to increased levels of ACTH. As we have seen, adrenocorticotropic hormone secreted by pituitary was increased, resulting in labial hyperpigmentation. Now, this was the basic idea, but as such, we need to find out the histological details of adrenal gland as well. Keeping your answer as the incorrect option, choice number D, let us proceed further with the details of the histological specimen of adrenal cortex, as well as little brief about adrenal medulla as well. Like, how do you know the three zones of adrenal cortex? How do you identify them? And how do you identify the adrenal medulla? Now, as we understand, in the lumbar region, we have the kidneys, and over the kidneys, we have the adrenal glands. Now, may it be the kidneys or the adrenal cortex that is coming from intermediate mesoderm embryologically. Whereas when we talk about adrenal medulla, you remember the adrenal medulla is derivative of neural crest cells, basically some of the sympathetic neurons. Anyhow, there's a problem of congenital adrenal hyperplasia. It is involving the cortex. So how do you identify the cortex and medulla? See, the adrenal gland, we have taken a histological specimen, and in the central region, we have the medulla. So this is the medullary region. Then, before you talk about the medulla, you should know about the cortex. So this is the peripheral cortex. And a specimen has been taken like this, which you find magnified here. So in the periphery, there will be a capsule, and this capsule will have some blood vessels like shown here. Now these blood vessels, like there will be 3 arteries supplying the adrenal gland, superior, middle, inferior, suprarenal arteries. And these arteries, as they reach the capsule of the adrenal gland, I mentioned they'll be sending some blood vessels. Few of them supplying adrenal cortex and the others supplying the adrenal medulla. And by looking at their anatomical orientation, we can differentiate the 3 zones of adrenal cortex. Let me show here. Say this is the adrenal artery in the capsule, sending branches into cortex and then branches into a medulla. Now the branches in the cortex will find in the region of zona glomerulosa. The blood vessels are arranged in a network of capillaries, fenestrated capillaries, or you can say fenestrated sinusoids, to collect the secretions of zona glomerulosa. In fasciculata, the blood vessels remain parallel in a longitudinal direction. So this will be in zona fasciculata, and as they reach the zona reticulata, again they assume a network of blood vessels. So by looking at this arrangement of vessels, you can tell this is going to be zona reticulata. And if you are talking about the adrenal medulla, you will notice that in the adrenal medulla, again there is some network of blood vessels. So this is adrenal medulla region. Now, what is the purpose of showing the arrangement of blood vessels? Because it will help us in identifying various zones here and the type of cells as well. You'll find in the zona glomerulosa, as the name is suggesting, there will be some cells, cluster of cells, making a glomerulus kind of arrangement, and interspersed will be the fenestrated capillaries or sinusoids. Whereas in the zona fasciculata, you will see cells are arranged in longitudinal fashion as a row in between. Say one row of cell here, another row of cell here, another row of cell here. So instead of making cluster of cells in zona glomerulosa like here, the zona glomerulosa, you'll find in zona fasciculata there are rows or columns of cells arranged parallel to each other. But again, as you come to zona reticulata, you'll notice there are cluster of cells. This time, reticulum, as the name is suggesting, zona reticulata, there is a network of cells. So a different arrangement of cells can be seen. So arrangement of cells and arrangement of blood vessels help us identify zona glomerulosa, zona fasciculata, and zona reticulata, as will be evident in the next diagram as well. And how will you identify adrenal medulla? Adrenal medulla, you'll find there are some sympathetic neurons, and the cells are becoming more basophilic. More of hematoxylin is taken, so that the bluish violet color is more prominent in the region of adrenal medulla. Plus, you will also notice just before adrenal medulla in the cortex, in the region of zona reticulata, the cells are more eosinophilic, pinkish appearance. So here, the cells are more pinkish. Then what about the cells of zona fasciculata? They are paler, less pinkish. And what about the zona glomerulosa? They are eosinophilic, but basophilic as well. That means bluish plus pinkish. So bluish plus pinkish, zona glomerulosa, more of paler arrangement, zona fasciculata, more of eosinophilic, zona reticulata, and more of basophilic, adrenal medulla region. Let us magnify these areas and talk more about them. The outermost region, as you see, is the capsule, and it will have some collagen fibers with blood vessels. And these blood vessels, as we mentioned, in the zona glomerulosa, they are making some network of fenestrated capillaries. But when it comes to zona fasciculata, they become elongated parallel arrangement of blood vessels, so that these cells in the region are also arranged in fascicles or columns. So zona glomerulosa, fasciculata and reticulata. In reticular zone, again you'll find the blood vessels are becoming more of a network. What about the arrangement of cells? As the name is suggesting, zona glomerulosa, cluster of cells. So these are the cluster of cells in zona glomerulosa. And what about the zona fasciculata? Zona fasciculata, they are making fascicles of cells, columns or rows of cells interspersed between the longitudinally arranged blood vessels. Okay. Then what about the reticulata? Reticulata, reticulum network formed by the cells. So it is kind of cluster of cells, but now they are making a network kind of arrangement. Okay, fine. What about the adrenal medulla? In the adrenal medulla, you have two types of cells. Neural crest cell derived ganglion cells, more of eosinophilic nature. And then there are chromaffin cells, which as we suggested will be taking more of hematoxylin and hence giving the bluish appearance in the adrenal medulla. So these are neural crest cell derived ganglion cells along with the chromaffin cells. Sometimes there can be tumors, pheochromocytoma. So that is involving the chromaffin cells of adrenal medulla, a neural crest cell derived tumor. But as we were talking about congenital adrenal hyperplasia, it was basically a problem of zona glomerulosa and fasciculata and further involving zona reticulata as well. You will notice these cells. Let me zoom a little bit. They have lot of vacuoles, and these vacuoles are basically representing abundance of lipid droplets, the steroid hormones being secreted, and it is more prominent in the zona fasciculata. Those vacuoles, they reduce in number as we come towards the zona reticulata or move towards the zona glomerulosa upwards. And that is why it is understood that zona glomerulosa is pinkish plus bluish. Eosin plus hematoxylin is being taken almost in equal amount, but here zona fasciculata is giving more of paler color because of more of vacuoles and less of staining. When it comes to zona reticularis, they take more of eosin because there are less of vacuoles. The lipid droplets reduce in abundance. Let us now magnify the actual histological picture showing the three zones of adrenal cortex. And as you can make out, the three zones of adrenal cortex, zone number A, zona glomerulosa, the cluster of cells is evident here. So these are the nuclei of the cells in the zona glomerulosa. These are the cells which are secreting the mineralocorticoids aldosterone. In this baby, due to deficiency of 21 beta hydroxylase, there was deficiency of aldosterone secreted by this region, hence salt wasting type of disorder. Plus, as you talk about zona fasciculata, you see these are the blood vessels we were talking about, arranged in a parallel fashion, and interspersed are the nuclei of these cells. They are also arranged in a longitudinal manner. Plus, you will notice the vacuolated appearance of these cells due to those lipid droplets, so paler in arrangement. These are the rows or columns of cells which you will find in the zona fasciculata, along with the parallel arrangement of blood vessels, the fenestrated capillaries. And then, as it comes to zona reticulata, it is evident this zone is taking more of eosin, pinkish appearance comparatively, and the cells, their nuclei, as you can notice, they are making a reticulum, a network of cells interspersed among the scattered fenestrated sinusoids. As compared to this region, they are making a network of capillaries and sinusoids. So zona glomerulosa, a cluster of cells towards the periphery, and zona fasciculata, fascicles of cells, well, parallel arrangement of blood vessels, and zona reticulata, more of pinkish eosinophilic cells, making reticulum or network of cells. The three zones of adrenal cortex, this one secreting the mineralocorticoids like aldosterone, and if it comes to zona fasciculata, they are secreting glucocorticoids like cortisol, more so in stress. It'll increase the blood sugar levels and reduce the immune response in the body. And when it comes to zona reticulata, this is the one which is giving us weak androgenic hormones. But in congenital adrenal hyperplasia, due to more secretions, our patient, that female, she was having masculinization, virilism, ambiguous genitalia, clitoral hypertrophy, all that. And before we finish here, you should understand how the adrenal medulla will appear. So that is the magnified picture here of adrenal medulla, and we have still magnified it here, mentioning that these cells are going to be two types. One is the ganglion cells, basically derivative of the neural crest cells, and interspersed will be the chromaffin cells also, and the one which are taking more of hematoxylin. Because of that only, they give more of bluish appearance as compared with the adrenal cortex. So this was the magnified view of adrenal medulla, along with few blood vessels, as you can observe here. The frustrated capillaries and sinusoids, which will obviously be there to absorb the secretions of adrenal medulla, which is adrenaline, noradrenaline. Adrenal gland is endocrine gland, so it is highly vascular. All the secretions are to be carried out by the blood vessels. And finally, you'll find the adrenal veins are formed, and these adrenal veins, they'll be carrying the endocrine secretions towards the systemic circulation. As we understand, it is one individual, 23-year-old, and brought to the emergency department in unconscious state. It was some motorcycle accident, and he has got a 10th rib fracture, which is on the left side. And now he is having severe hypertension. See, this kind of a picture is very typical of spleen rupture. There is tachycardia, there is feeble peripheral pulse. That means he is undergoing shock. Left-sided 10th rib, the long axis of spleen, 9, 10, 11th rib. So in this road traffic accident, there is a splenic rupture leading to massive bleeding, and once diagnosed, you are supposed to open up the patient, and in many cases, you might have to do splenectomy due to extensive damage. Anyhow, the organ has been removed and is being examined. Some histopathological specimen has been taken, and we have observed two vessels. Now, there are two major blood vessels, that is splenic artery and the splenic vein. That's what is shown in the image. And we have to compare them so as to answer the true statement. The question is asking us about the true statement. So before we start looking at the options, first of all, you can understand there is a lumen seen on this side and another on the other side. Plus, what I understand is the blood vessels, normally towards the lumen, they'll have a tunica intima. Then there'll be a tunica media and then tunica externa. Now, let us see. This appears to be the tunica intima, and it is towards the lining surface of the lumen. The blood vessels will have blood passing. To keep the surface smooth, you must have simple squamous epithelium. And not only there'll be a simple squamous epithelium, the endothelium, but there'll be subendothelial connective tissue also in the tunica intima. Now, next will be tunica media. As you can see, this big region is the tunica media. And tunica media, mostly it is seen smooth muscles found here, but then it depends if it is an elastic artery, which are near to the heart, like pulmonary trunk or the aorta, then they can have more of elastic fibers. So there can be elastic fibers, and there'll be more so if it was an elastic artery. But how do you know that this is an artery? And how do you know that it is not elastic artery, but a muscular artery having more of smooth muscles? Because spleen, the splenic artery, is a muscular artery which has the function of regulating blood flow towards the organ. Anyhow, we'll talk more about the muscular elastic arteries. But then this region is the tunica externa. And tunica externa is mostly collagen fibers, plus there will be elastic fibers also. Now, you have assumed that this vessel is an artery. How do you know that this vessel is an artery? And this vessel is a vein, because it's a simple concept. A vein will have larger lumen but thin wall. So the components of the wall are thin as compared with the artery. Let us draw a schematic diagram of artery as well. In case of an artery, the lumen will be small, and comparatively the components of the blood vessel wall will be thicker. And more so, when you compare an artery with a vein, it is understood artery will have thick wall and vein will have thin wall. The tunica media in case of an artery is significantly large as compared with the tunica media of a vein. Let us mark the three components of this blood vessel, the vein as well. And you notice, lining the lumen to keep the surface smooth, we have tunica intima. And this tunica intima will have the endothelium, that is the simple squamous epithelium, plus along with that will be some subendothelial connective tissue as well. Then what is deep to that? This is the tunica media, and tunica media will have smooth muscle cells. Now you will notice one peculiar thing. In case of a vein, the tunica externa is quite large compared with tunica media. In fact, if you look at the proportion, it'll be like tunica externa is 2/3 of the vessel wall and tunica media is 1/3. So tunica externa is 2/3 of the proportion as compared with the tunica media, which is 1/3 in proportion. But on the other hand, if you are comparing it with an artery, it is the reverse. In an artery, the tunica media is 2/3 of the proportion, whereas the tunica externa is 1/3. That means in an artery, tunica media is significantly larger than the tunica externa. Now, let us focus upon the choices. This question wanted us to know the true statement regarding the major blood vessels within the organ. The organ is spleen. So, vein has thick tunica media compared with the artery. And what do you think about this statement? Actually, it is a wrong statement because we have just mentioned veins. The tunica media is thin as compared with the artery. See, this is the tunica media of a vein, and that is the tunica media of an artery. So, obviously, choice number A is a wrong statement. Let us look at choice B. The vein is having prominent internal elastic lamina. Now, what is that? Internal elastic lamina is made up of elastic fibers and is at the junction of tunica intima and tunica media. It will be more prominent in case of an artery rather than a vein. So the point is, when it comes to internal elastic lamina, it is definitely present in a vein, but it is more prominent in an artery. We'll see as a diagram, a magnified view where you can clearly see internal elastic lamina, especially in an artery. So that means choice number B is also a wrong statement, because it is the artery which will have prominent internal elastic lamina. Now, if B is also a wrong statement, what about the choice number C? Is the artery having thicker tunica media than its adventitia? And for that, I can say it is a correct statement because we have already seen The ratio in an artery about the tunica media is 2/3 compared with tunica adventitia 1/3. You see, tunica media is 2/3, tunica externa, which is also called tunica adventitia, some connective tissue, some collagen fiber, elastic fibers. So that tunica adventitia, tunica externa was 1/3. Hence, if you're asking the true statement, then I'll go for choice number C. Artery has thicker tunica media, 2/3, as compared with its adventitia, which is 1/3. So if choice C is the answer, what about choice D? Of course, it'll be a false statement, but let us check it. Choice number D is telling artery has several elastic fibers scattered through the tunica media. Now, this statement will be a true statement, but in case of elastic artery, like I said, aorta or pulmonary trunk, which are close to the heart, not the splenic artery. Splenic artery is not elastic artery, it is a muscular artery. It will have more of smooth muscles in the tunica media and not the elastic fibers. Elastic fibers are required in blood vessels like aorta and pulmonary trunk. When there is systole and the heart is pushing the blood, that high pressure blood is taken by the vessels like aorta and they stretch. And during diastole, they'll contract and push the blood further into the body. So they are kind of accommodating the pressure by virtue of their elastic wall. During systole and diastole, they kind of provide a buffering of blood pressure. But in case of organs like spleen, they are actually muscular arteries with more of smooth muscles, and those smooth muscles in the tunica media are meant for controlling the flow of blood vessel into the organ. So statement D may be true for aorta but not for splenic artery. So it is a wrong statement, and hence only true statement in this question is choice number C, and that should remain as our answer. Let us now magnify this region and discuss more details of a splenic artery and then compare it with splenic vein as well. Now, as we said, if we are talking about the splenic artery, and that is the luminal side, there will be a tunica intima, and that tunica intima is going to have endothelium, which is in fact the simple squamous epithelium, keeping the luminal side of the blood vessel smooth. You don't want any thrombus formation in the flowing blood. So, tunica intima means it is a simple squamous epithelium along with some connective tissue, subendothelial connective tissue. And then comes the tunica media. As you talk about significantly larger, you will notice at the junction of tunica media and tunica intima, there is one internal elastic lamina. And that internal elastic lamina, as you can see, is made up of elastic fibers. So it is the boundary line of tunica intima and tunica media. That internal elastic lamina is made up of elastic fibers and will be fenestrated also. And why do you need fenestration? Because it is understood the blood vessel wall requires oxygen for survival, and that oxygen, which is being carried by the blood cells, the hemoglobin, the RBCs, that transport of oxygen to various levels of the tunica intima, media or externa, the internal elastic lamina must be fenestrated. So, internal elastic lamina, which is made up of elastic fibers, is the boundary line between tunica intima and tunica media, is more prominent in case of an artery, especially the muscular artery. It is more prominent. So here it is shown internal elastic lamina. Now, once you have described that elastic fibers, internal elastic laminal boundary line between tunica intima and tunica media, what do you find in tunica media of a muscular artery like the splenic artery? The tunica media is having more of smooth muscle cells. Though you will notice that there are some elastic fibers also present, but more of smooth muscle cells like shown here. These are the smooth muscle cells, spindle-shaped cells, less of elastic fibers. Comparatively, if you look at the aorta, it'll have more of elastic fibers and less of smooth muscles. So there'll be a difference between one elastic artery, and this is actually a muscular artery, more of smooth muscle cells, as are evident in this diagram also. This diagram is specifically stating more for elastic fibers. Anyhow, we have seen one internal elastic lamina. There is one external elastic lamina also. And that external elastic lamina will be at the next junction. That means it is going to be located at the junction of tunica media and tunica externa, which is also called tunica adventitia. So it will be here, external elastic lamina, the junction of tunica media and tunica externa, which is also called as the tunica adventitia. The same external elastic lamina you can show in the artery here as well. So this is the external elastic lamina made up of some elastic fibers at the boundary line of tunica media and tunica adventitia. The tunica adventitia, which is also called tunica externa, is going to have some collagen fibers and elastic fibers, as is evident here as well. Some elastic fibers, some collagen fibers. The tunica externa. Now, once you have demarcated the tunica externa of the splenic artery, it is seen merging with the tunica externa of the splenic vein here. So this is the splenic vein lying exactly opposite. And let us look at the details of splenic vein as well. Compare it with the artery. And immediately you can notice that this tunica externa or tunica adventitia of the vein is significantly larger as compared with the tunica media, which is here. This is the tunica media of the vein. And if you compare the proportion, you will find tunica adventitia is 2/3 and tunica media is 1/3 in proportion. Now, once you say 2/3 and 1/3 ratio of the tunica media, tunica externa, you will notice even in case of a vein, the tunica adventitia is made up of collagen fiber, elastic fiber. But additionally, there can be smooth muscle cells as well. See, the difference between the tunica adventitia of a vein and an artery is the tunica adventitia of a vein is larger compared with the tunica media. On the other hand, the tunica adventitia of an artery is comparatively less thicker than the tunica media, as it is observed. And moreover, the difference which I want you to understand is, in an artery, the tunica adventitia will have collagen fiber, elastic fibers, but in case of a vein, the tunica adventitia, along with that collagen elastic fiber, can have smooth muscle cells as well. So splenic vein can have smooth muscles in the tunica adventitia, but still, if you go for larger veins like inferior vena cava, in inferior vena cava, tunica adventitia will have a lot of smooth muscles. Now, since we are talking about splenic vein, the smooth muscles will be more prominently seen in the tunica media. So these are all smooth muscle cells, and there will be very few elastic fibers. So tunica media of a vein will have mostly smooth muscles. What about the tunica intima? Tunica intima, as we said, will be some simple squamous epithelium with subendothelial connective tissue. But then, as we have observed, the internal elastic lamina or external elastic lamina are not prominent in case of a vein. They are more prominent in case of an artery, and especially a muscular artery will have prominent internal elastic lamina, as was evident here. It can have external elastic lamina also evident. These lamina, they are not that much evident in case of a vein. And remember one more thing, this tunica adventitia, or what is called tunica externa, in case of larger veins like inferior vena cava, there you have vasa vasorum, means blood vessels of the blood vessels. So tunica adventitia can have small blood vessels. Why do you need small blood vessels In the wall of a vein, those vasa vasorum, they will be the source of oxygen, nutrients, excretive products to be removed from the walls of a vein. Though they may not be that evident in case of splenic vein, they'll be more evident in the tunica adventitia of larger veins like inferior vena cava. Because in those vessels, you don't have oxygen in the lumen. It's a vein. Inferior vena cava carries deoxygenated blood. You cannot send oxygen from here. So how will the vessel wall survive? How will you give oxygen? To give oxygen to the vessel wall of a vein, you do not have oxygen in the lumen. This is all deoxygenated blood. So you need to have few blood vessels in the vessel wall. That will perform the function of oxygenation. Vasa vasorum in the tunica adventitia of a vein especially, though you can have vasa vasorum in the tunica adventitia of an artery as well, like aorta. Aorta is having such a thick wall that the oxygen coming from the lumen may not reach the tunica adventitia. So even larger arteries in the tunica adventitia, they can have vasa vasorum. And this vasa vasorum in the tunica adventitia will be more prominent. Not in case of muscular artery like this splenic artery. No, it will be more prominent in case of larger vessels like aorta. What we notice here is a patient has presented to us with some paresthesia at the anterolateral aspect of the forearm, means some sensory disturbance, and then upon examination there was some associated motor symptomology as well. Now, the surgeon has planned that the patient might be needing a nerve transfer, a surgical candidate for nerve transfer. The question is asking us, which nerve are you planning to transfer? Identify the nerve. Now the arrow mark has been given and some options are given. This is actually right-sided brachial plexus, starting from the neck region, passing behind the clavicle bone, reaching the axilla, and in axilla some branches are given. One of the branch which supplies anterolateral aspect of the forearm, that is arrow marked here. And by our knowledge of anatomy, lateral cutaneous nerve of forearm, the continuation of musculocutaneous nerve. Musculocutaneous nerve is called so because it supplies three muscles in the anterior arm and supplies the skin as well, musculocutaneous. So which three muscles it is supplying in the anterior arm? They are coracobrachialis muscle coming from coracoid process of scapula to the brachium, and number 2, it is the biceps brachii, and number 3, it is the brachialis muscle. So three muscles and some part of the skin, musculocutaneous nerve. Now maybe you have got your answer here. Choice number A is your answer. But then we have to discuss some details of the nerve. How did you identify it? Of course, along with the clinical features, but how did you identify in the diagram? And what about the median nerve, radial or ulnar nerve? If next time the question changes, how will I identify the other nerves given by the brachial plexus? And for that, let us zoom this diagram. And as we do that, remember brachial plexus has 5 root values starting with number 5, the C5. And after that, you can say C6, 7, 8, and also T1. Given in the neck region, anterior primary ramus. Let us show them here. In the neck region, you have the C5 and then C6, 7, 8, and T1 as well. The anterior primary ramus coming from the spinal cord. Then we'll find these roots will join to form the trunks of brachial plexus in the neck region. Roots and trunks are in the neck region. Divisions pass behind the bone clavicle, and cords and branches are in the axilla. So roots and trunks. There are 3 trunks in the brachial plexus: upper trunk, middle trunk, and lower trunk. How they are formed? It is the C5 and C6 roots which are going to form upper trunk of brachial plexus, whereas the middle value, that is C7, will continue as the middle trunk of brachial plexus. And then C8, T1 roots the axons, they will join to form the lower trunk of brachial plexus. These trunks are in the neck region. Now trunks, they give anterior and posterior division. Before you start talking about those divisions, let us show these details in this diagram as well. First of all, let us mark some muscles here. This is the scalenus anterior muscle, which is in the neck region and is inserting on the inner border of first rib. This scalenus anterior muscle lies anterior to the brachial plexus. It also lies anterior to this vessel, which is subclavian artery. Now here is the subclavian artery. Subclavian artery actually was passing behind the scalenus anterior muscle. That will be the second part of subclavian artery. The third part of subclavian artery lies distal to scalenus anterior muscle. As the subclavian artery will cross the first rib, it will enter the axilla, it will become axillary artery. And that axillary artery have been removed but partly seen here. So this is the continuation of the axillary artery, which itself is giving some branches we need to focus upon. So this axillary artery is important in the axilla because in relation to that axillary artery, you have three cords of brachial plexus in the axilla, named according to their relation with the axillary artery. But before you start talking about the cords in the axilla, let us first mark the roots and trunks in the dissected specimen. So here, as you say C5 and C6 root, they are shown here, C5 and C6 root. So they are going to join and form the upper trunk of the brachial plexus. This is the upper trunk of brachial plexus in the neck region. Now, once you have shown the C5, C6 roots axons joining to form the upper trunk, what about the middle trunk? The middle value C7 continues as middle trunk. So you can see this is the middle trunk. The C7 root continuing as the middle trunk. Now, once you have marked the middle trunk, what about the lower trunk of brachial plexus? The lower trunk is C8 and T1, as you see, C8 and T1 joining to form the lower trunk of brachial plexus. Here is the lower trunk. Now, roots and trunks, they are in the neck region. After that, each trunk is giving anterior and posterior division. And presently, let us just focus upon the anterior division of the three trunks. So, where do you find these anterior division? They will be passing behind the bone clavicle, which have been removed from here to maintain the clarity. So, can we mark the anterior division of the three trunks here? Yes, let's do that. In fact, the anterior division of the upper trunk and middle trunk will be forming lateral cord of brachial plexus. Anterior division of upper trunk and anterior division of middle trunk will be forming lateral cord of brachial plexus. Show it in the diagram. You will notice upper trunk has given the anterior division, middle trunk has given the anterior division, and together they have formed the lateral cord of brachial plexus. There are three cords of brachial plexus: lateral cord, medial cord, and posterior cord, named according to their relation with the axillary artery. Say, if we have the axillary artery here, then there is a cord which is running lateral, so lateral cord, and there is a cord which is running medial, so medial cord, and there is one which will be running posterior, so posterior cord of brachial plexus. Just now you have shown the lateral cord of brachial plexus. Can you show the medial cord as well? Yes, let's do that. The anterior division of the lower trunk brachial plexus continues as the medial cord of brachial plexus, lying medial to the axillary artery. So this is the medial cord of brachial plexus, continuation of the anterior division of lower trunk. What happened to the anterior division of upper and middle trunk? The anterior division of upper and middle trunk, they have joined to form the lateral cord, whereas anterior division of lower trunk will just continue as medial cord of brachial plexus. Let us show that here now. And this is the medial cord of brachial plexus. Now, if you say this is the medial cord of brachial plexus, then where is the posterior cord of brachial plexus? Posterior quadribrachial plexus we'll be discussing in the next diagram just for the sake of clarity, but at the moment you can just remember the posterior cord of brachial plexus will be lying posterior to the axillary artery, and the posterior cord of brachial plexus is formed by posterior division of the three trunks of brachial plexus. As I told you, each trunk of brachial plexus in the neck region will give 3 anterior division and 3 posterior division. Those posterior divisions will be contributing towards the posterior cord of the brachial plexus, which will be running posterior to this axillary artery. So the posterior division of upper trunk and the middle trunk and the lower trunk, they'll be forming the posterior cord of brachial plexus running posterior to axillary artery. Fine. That is the posterior cord of brachial plexus. But can you show posterior cord in this diagram? Yeah, let us see here. This is the posterior cord of brachial plexus, and we'll be skipping it here at this moment because we have a separate diagram for posterior cord. Okay, so let us quickly revise here. How many roots we have? We have 5 roots of brachial plexus in the neck region. How many trunks we have? We have 3 trunks of brachial plexus in the neck region, upper, middle, lower trunk. And how many division? We have 6 division, 3 anterior, 3 posterior division, passing behind the bone clavicle. And how many cords we have? 3 cords of brachial plexus named according to their relation with the axillary artery, lateral to the artery, medial to the artery, or behind the artery. Posterior cord, medial cord, and lateral cord, out of which we are skipping posterior cord at the moment, and we'll just continue with the lateral cord and medial cord. Remember, lateral cord of brachial plexus continue as musculocutaneous nerve, whereas medial cord of brachial plexus will continue as ulnar nerve. So let us focus upon those two now. You start with lateral cord continuation here. And you see, this was the lateral cord of brachial plexus, continuing as the musculocutaneous nerve. And this musculocutaneous nerve, the arrow mark, is called musculocutaneous, supplying 3 muscles in the anterior and then supplying the anterolateral skin on the forearm. So here is the musculocutaneous nerve. What about the continuation of medial cord of brachial plexus? Medial cord of brachial plexus continue as ulnar nerve, and which you can show now. So this is the medial cord of brachial plexus continuing as the ulnar nerve here. How do you know this is ulnar nerve here? Because if you follow this nerve, you will see downward it is going on the medial aspect of the arm and forearm, and on the medial aspect of the forearm you will have the ulnar bone, hence ulnar nerve. So you are telling ulnar nerve is continuation of the medial cord, musculocutaneous nerve is the continuation of lateral cord. What is the continuation of the posterior cord of brachial plexus? Posterior cord we are not discussing here, but let me tell you, it is the radial nerve. And if you want to see the radial nerve here, this is the radial nerve, the thickest of all these nerves. And why would the radial nerve be thickest of all these nerves? Because it has all the 5 roots of brachial plexus. And where is it going? Radial nerve goes behind the bone humerus and supplies muscles of the posterior arm and forearm, supplies skin on the posterior aspect of upper limb. Now, that was about the posterior cord of brachial plexus continuation. At the moment, where is median nerve? And to find the median nerve, you make one M. M for median nerve. Yes. And where is that M? See, this is the median nerve. How do you know this is the median nerve? Because it is in the midline. See, laterally musculocutaneous, medially the ulnar nerve, posteriorly is the radial nerve. So now whichever thick nerve left must be the median nerve. Thick, how thick? Just like radial nerve. But you told that radial nerve is the thickest of all these nerves because it has all the 5 roots of brachial plexus. Yes, even the median nerve can have 5 roots of brachial plexus. So it will be almost the same width of the radial nerve? Almost. You just feel it during dissection and you will know. But anyhow, for median nerve, make one M. Where is the M? You see, this is the M. This is the M. How is this M? And as you can understand, median nerve is contributed by not only lateral cord, but also medial cord. So, median nerve is contributed by lateral cord as well as medial cord of brachial plexus. And if you want to see the M, then it is here. This is the M. The middle limb of M is the median nerve. Otherwise, this is musculocutaneous nerve, one of the limb, and the other limb is ulnar nerve. Can you show that M here as well? Schematic diagram. Okay. You see, this is the median nerve, contributed by lateral cord as well as the medial cord. And as you show the contribution, you can mention median nerve is formed by the lateral cord of brachial plexus as well as medial cord of brachial plexus. The medial cord of brachial plexus continuing as the ulnar nerve as seen here. And if you're talking about the lateral cord of brachial plexus, it'll continue as musculocutaneous nerve as shown here. And this is the M. So in the M, the middle limb is the median nerve itself, whereas one of the limb is musculocutaneous nerve and the other is ulnar nerve. So can you see that M here? This is the M, median nerve. And you can continue the median nerve here now, running in the middle of the arm region, downwards. So this is the median nerve. What is it going to supply? The median nerve is running in the midline of the arm, is going to supply muscles of the anterior forearm and some muscles in the hand towards the thumb. So most of the muscles in the anterior forearm and some muscles in the hand towards the thumb will be supplied by median nerve. Okay, and what is this ulnar nerve supplying? Ulnar nerve goes with the ulnar bone. Supply few muscles in the anterior forearm and most of the muscles in the hand. So most of the muscles in the hand are supplied by ulnar nerve along with few muscles in the anterior forearm. So basically, which nerve is the nerve of anterior forearm muscles? Median nerve, partly ulnar nerve. And which nerve is the nerve of hand muscles? It is mainly ulnar nerve and partly median nerve. Ulnar nerve is having more supply in the hand, less in the forearm. And the median nerve is having more supply in the forearm, less in the hand. So that means anterior forearm and hand muscles are supplied by only two nerves. Yes, their names are median nerve and ulnar nerve. Then what is musculocutaneous nerve doing? Musculocutaneous nerve supply three muscles in the anterior arm, namely coracobrachialis, biceps brachii, and brachialis muscle. So that was a problem. In our patient, there was some motor problems related with the three muscles of the arm and also paresthesia to lateral aspect of the forearm. This was the arrow. That was our answer. You will notice here is the coracoid process of the scapula and two muscles attaching here. One of them is the coracobrachialis muscle coming from coracoid process to the humerus bone, coracobrachium muscle, and the other is short head of biceps brachii. And may it be the biceps brachii or coracobrachialis, they are being supplied by musculocutaneous nerve. It's going there, will supply them along with third muscle, brachialis muscle. Since this nerve was not working properly, the surgeon has planned a surgical transfer of this nerve in the patient. And then let's move on to the next diagram to talk about the posterior cord of brachial plexus and its branches. And as we were telling, this is the right-sided brachial plexus, partly seen in the neck region, passing behind the bone clavicle, then in the axilla and giving some branches. This time we focus upon the posterior cord of brachial plexus after removing all the further details so that clarity is maintained. Revising the details, we have earlier seen this is the scalenus anterior muscle in the neck region, and it is supposed to insert on the scalene tubercle on the inner border of the first rib. The artery which passes behind that is subclavian artery. Here it will be the third part of subclavian artery distal to the muscle. Behind the muscle you have the second part of subclavian artery. If you go still more proximal, it is the first part of subclavian artery. So subclavian artery is divided into three parts. Biscalenus anterior muscle, proximal to the muscle, deep to the muscle, and distal to the muscle. Now, as the subclavian artery crosses the outer border of first rib, it will enter the axilla, become axillary artery. And axillary artery itself is divided into three parts by another muscle, pectoralis minor muscle, inserted on the coracoid process. We have removed the pectoralis minor muscle here so that you could see the third part of axillary artery. So, how do you know that this is the third part of axillary artery? Because third part of axillary artery lies distal to pectoralis minor muscle, and it gives three branches. Which three branches the third part of axillary artery will give? You see, one of the branch is going under scapula, so it is called subscapular artery. And what about the other two branches? There is one going anterior and another one going posterior to the humerus. So they are called anterior circumflex humeral artery and posterior circumflex humeral artery. They go around the surgical neck of the humerus. Anterior and posterior circumflex humeral artery branches of the third part of axillary artery. Yes, this is the third part of axillary artery, giving three branches. And also notice, once this artery will cross the lower border of teres major, it will become brachial artery. It's the brachial artery which is going to give us a branch which is important here, namely profunda brachial artery. And this profunda brachial artery, which is a branch of the brachial artery, is followed by a radial nerve. This is the radial nerve. Now, before we talk about radial nerve, just give some more details of the artery here. The third part of axillary artery, as it gives subscapular artery, it further divides into two. And one of them goes around the scapula. You say circumflex scapular artery going around the scapula, and the other thoracodorsal artery. And this thoracodorsal artery will be followed by thoracodorsal nerve. And where is this thoracodorsal nerve coming from? It is also a branch of the posterior cord of the brachial plexus. Remember, 5 branches from the posterior cord of brachial plexus, stars. Now, when you say posterior cord of brachial plexus is giving us 5 branches, the stars, what is the full form of stars? That is what we will discuss. But first you mention how the posterior cord of brachial plexus formed. Now, this is the posterior cord of brachial plexus, and it was formed by posterior divisions of the 3 trunks of brachial plexus. You can see again, this is C5 root, C6 root. Together they are going to join and form upper trunk of brachial plexus, whereas this is C7 root forming the middle trunk of brachial plexus, and then C8 and T1 roots together joining to form the lower trunk of brachial plexus. So this is the lower trunk of brachial plexus. Now, upper trunk, middle trunk, lower trunk, each will give one anterior division and one posterior division. This time we are focusing upon posterior division only. So posterior division of upper trunk, middle trunk, lower trunk, they are given, pass behind the bone clavicle, and then join to form posterior cord of brachial plexus. So posterior division of the upper trunk, posterior division of the middle trunk, and posterior division of the lower trunk, they have joined to form the posterior cord of brachial plexus. Posterior division, they are passing behind the bone clavicle, which we have removed here for the sake of clarity. And then in the axilla you have posterior cord of brachial plexus, which is going to give us 5 branches. But remember, the continuation is radial nerve. So radial nerve is the continuation of the posterior cord of brachial plexus. As you can see here, the thickest of all the branches, having all the 5 root values of brachial plexus, as is evident in this diagram. Now, if R is the radial nerve, what is this A? A is the axillary nerve. And you will notice the axillary nerve, which is a branch of the posterior cord of brachial plexus in the axilla, is going to pass in the quadrangular space and follow posterior circumflex humeral artery. So posterior circumflex humeral artery and axillary nerve together, they are passing the quadrangular space, and together they will be passing around the bone humerus, around the surgical neck of the humerus. That is about the axillary nerve. What was the radial nerve passing through? The radial nerve along with profunda brachial artery will be passing lower triangular space. And after passing the lower triangular space, it will be going behind the bone humerus, posterior to the humerus in the radial groove. So the radial nerve and profunda brachial artery, deep artery of the arm coming from the brachial artery, they will be passing lower triangular space and running in the radial groove behind the mid-shaft humerus posteriorly in the posterior arm. Now, what about the T here? What is this T? T is the thoracodorsal nerve going dorsal to the thorax, and you can see it here. Coming from the posterior cordobrachial plexus in the axilla, this thoracodorsal nerve, it is going to supply latissimus dorsi muscle. Okay, then what is this? Upper S and lower S. These are the nerves under scapula, supplying the muscle under scapula. Upper subscapular nerve, lower subscapular nerve. Not clearly seen here, but will be supplying this muscle here under the scapula. And who is this muscle under the scapula? That is the subscapularis muscle. So the name of the nerves are upper subscapular nerve and lower subscapular nerve, supplying the subscapularis muscle, making it hybrid. A hybrid muscle will have more than one nerve supply. Here it is having two, both of them coming from the posterior cord of brachial plexus. So posterior cord of brachial plexus gave you 5 branches, remembered by the mnemonic stars.